Hi, I'm Igor, and today we will go talk about Kawasaki disease, or also known as mucocutaneous lymph node syndrome. Kawasaki disease is an acute necrotizing vasculitis of unknown etiology. The condition primarily affects children under the age of 5 and is more common among those of Asian descent. Epidemiology: more in men than women. Age: primarily children less than 5 years, most commonly case of acquired coronary artery disease in children. Peak incidence occur mostly in late winter and spring. The exact case of Kawasaki disease remains uncertain. However, it is associated with infections and genetic factors. The prevalence is higher in patients with Asian descent and in siblings of affected children. Clinical feature is require fever for at least 5 days and one of the following: four equal 4 or more than specific symptoms, or less than 4 specific symptoms, and involvement of the coronary arteries. Specific symptoms include erythema and edema of the hand and feet, including the palm and soles. The first week, possible desquamation of fingertips and toes after 2-3 weeks. Polymorphous rash originated on the trunk, painless bilateral injected conjunctivitis without exudate. Oropharyngeal mucositis is erythema and swelling of the tongue, and strawberry tongue, cracker and red lips. Cervical lymphadenopathy, mostly unilateral. And this we see in this photo desquamated rash, desquamated pelvis and soles in children in Kawasaki disease, strawberry tongue, rash on the back, and conjunctivitis. Non-specific symptoms may be in patients with Kawasaki disease is diarrhea, fatigue, abdominal pain, arthritis, hoarseness, breathing difficulties. Always consider Kawasaki disease in small children with rash and high fever, unresponsive to antibiotics. Mnemonics for this disease is crash and burn. C. Conjunctivitis. R. Rash. A. Adenopathy. S. Strawberry tongue, hands and feet, and burn fever more than 5 days are the most common feature of Kawasaki disease. Laboratory findings: ECR increased erythrocyte sedimentation rate and C-reactive peptide leukocytosis, thrombocytosis, and increased AST and ALT. Echocardiography for evaluation coronary artery aneurysm. Minimal evaluation should be performed at diagnosis at 2 weeks and at 6 to 8 weeks after onset. Treatment include immunoglobulin intravenous, is a single dose to reduce the risk of coronary artery aneurysm, most effective if given with the first 10 days following disease onset. High dose oral aspirin. Intravenous glucocorticoids may be considered in addition to standard treatment, especially in cases of refractory treatment disease, as they lower the risk of coronary involvement. To avoid the risk of Rett syndrome, children should not be treated with aspirin, especially if a viral infection is suspected. Kawasaki disease is an exception to this rule. We can give aspirin to the children in this case. Complications of this disease include coronary artery aneurysm. The risk of aneurysm highest during the second and third weeks following symptoms onset. Rupture or thrombus of the aneurysm can be lethal. Myocardial infarction, myocarditis, ventricular dysfunction most commonly occur within the first 2 weeks of onset of Kawasaki disease. Often seen in infants with untreated Kawasaki disease, most commonly associated with lymphocytic myocarditis. Manifest with symptoms tachycardia or diaphoresis with feeding, exertional dyspnea, and physical examination finding of congested heart failure. For example, hepatomegaly, S3 gallop, Rales or cracks on lung auscultation increase risk of sudden death. Thank you. Subscribe to the channel.